Okay, time for another Puscast covering the last 2 weeks in April in the year 2020. References, as always, are at edgydoc.com, the home of my stagnant multimedia empire of blogs, podcasts, apps, books, lions and tigers and bears, oh my. This will be, I think, a COVID-free Puscast. So much is happening that anything I say today is likely to be wrong tomorrow. Case in point, end of March, I told my colleagues that I bet the United States was going to see 100 million cases and with a 0.1% mortality rate, 1 million deaths in the upcoming 18 months, and that we would probably be plagued by COVID for 2 years. Watching the response unfold in the United States with the lack of masks, the lack of PPE, the lack of social distancing, etc., I'm starting to think that I was actually overly optimistic with my prediction. You can probably double that number in the next 18 months to 2 years at the rate we're going. Unless, of course, we get a vaccine. But let's move on to the rest of the infectious disease literature, shall we? First up, an antimicrobial toxicity article. This one found a patient on ceftaroline who is also in renal failure and had ceftaroline-induced encephalopathy. The penicillins and cephalosporins can be neurotoxic, and if you get a lot of drug in someone who doesn't have much in the way of GFR, drug will accumulate, patients will have complications like encephalopathy. So in 28 patients with a GFR less than 30, 3 of whom eventually developed an encephalopathy due to, quote, supratherapeutic blood concentrations. So the take home, as is always the case in people who can't clear their antibiotic, beware of drug toxicities. It's always a question of how clean a stethoscope is. This study cultured the stethoscopes of a wide variety of healthcare providers, residents, medical students, attendings, nurses, respiratory therapists, and they found overall 91% of the stethoscopes had bacteria on them, and this was irrespective of whether or not the stethoscope owner claimed that they sterilized or cleaned their stethoscopes per the CDC guidelines. And this points to the stethoscope as a potential vector for the spread of pathogens in the hospital. I treat my stethoscopes myself like my hands. If I'm going to touch a patient with either, I foam them, and when I'm done, I immediately foam them. My personal message when I'm talking about hand hygiene in the hospital is that when you walk out of a patient's room, you should be comfortable licking any part of your body if you could reach it. I don't think I could get my elbow to my tongue. Or you should feel comfortable licking any of the equipment you haul out of the room. Because when you go to lunch and pick up a sandwich, that's exactly what you're going to do. We're all aware of the issues of COVID currently on cruise ships, and cruise ships are routinely called petri dishes. Is calling a cruise ship a petri dish the right metaphor? It doesn't seem quite right to me. Petri dishes are good for growing an organism, but not particularly good at spreading them, as people usually don't lick or eat petri dishes. Children are petri dishes. We just need a better metaphor, I think, for the infectious capacity of a cruise ship. And I'm sorry to say, one's not coming to mind. That being said, there are many other outbreaks associated with cruise ships, including norovirus. This study looked at the origin of a norovirus outbreak on a cruise ship, and they traced them to the frozen raspberries purchased from China. Or as a very stable genius might pronounce it,
let's say China. China, 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 China. You go over to China, 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 China. You take China. 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 I love them. China. China. China, China, China. I have to have my China. China, China, because China, 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 China. China, 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 China now, China, China. You know, China. I know China very well. China, 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 China.
Northwest Wisconsin, where I'm from.
It's China to me, China. China, 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 China. You want to buy from China? That's great. Buy from China. Buy toys from China. China in particular. China, China. I have people that I know in China. China, China. China, China, China. China, 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 China. I've been saying China, 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 China.
It actually goes on another 2 minutes, and I think I'll spare you. But the take home really is that the food supply is globalized, and with it comes global infections. We are always a cough, an airplane, or a package of frozen raspberries away from getting a new infection. Yet another reason, as I've said before, to deep fry all your food. MERS, so last year. But this study looked at the outcomes of critically ill patients with the Mideast coronavirus and whether or not they responded to ribavirin plus interferon. And the answer was, at least in critically ill patients, no. The combination of ribavirin with a variety of interferons did not decrease mortality, nor did it lead to faster clearance of MERS-CoV RNA. And the vast majority of patients got the therapy within 1 to 2 days of hitting the ICU, so they intervened early and did not get a response to the therapy. I'm of a mind that any virus that you can't start within 48, 72 hours for your antiviral, you're not going to get much of an effect. That will probably be the big problem with remdesivir is intravenous. So you have to be sick enough to get in the hospital. And by that point, you're probably well into your illness and past the point where you'll get a good response to something like remdesivir. What we really need, besides a good 5-cent cigar and a chicken in every pot, is an oral therapy that people can start immediately with symptoms. And who knows when that will be available. Sorry, I said I wouldn't talk about COVID, and I already have twice. So who knows what else I'll say. A large part of this podcast is allowing me just to whine, and I will whine about the fact I've always hated the concept of the flu-like illness, since for many people the flu is virtually any syndrome. For example, what the hell is stomach flu? But if you have a febrile coughing illness, that would be, in my mind, a nice definition for a flu-like illness. Besides influenza, this study out of New York showed that an adenovirus 7D, that's a 7 and the letter D, not 7 tens or 70, can cause a flu-like illness. So when the patient's flu negative and COVID negative, and you're going to keep sending COVIDs off until you get a positive response, also consider other viral pathogens as a cause of your patient's syndrome, such as adenovirus. So here's some curious pathophysiology of infections. It turns out that viruses kill neutrophils in a unique way, and they call it netosis. Big N, big E, big T, osis. And during netosis, these neutrophils release, quote, neutrophil extracellular traps, nets, that are composed of uncoiled chromatin DNA, histones, granule proteins such as myeloperoxidase, neutrophil elastase, and lactoferrin. And these nets help fight the infection due to viruses early on, but if you do not clear your nets, or if you produce too many nets, I guess you'd call it a net storm, like a cytokine storm, a term I've never been fond of, then you get a worser outcome. This study looked at the presence of nets, i.e. circulating free cell DNA, in patients with severe fever and thrombocytopenia syndrome, which is a phlebivirus in the Bunyaviridae family that causes diseases in China. Should I go and list the China stuff again? Nah, you probably don't want to hear that. And they found that in patients who had a high degree of nets in their blood had a worser outcome. and it was specifically high levels of cell-free DNA. So it's only a matter of time, I suppose, until we have an article that has the title Operating Without a Net or some such. But still, it's an interesting bit of pathophysiology in response to viruses. Half, well, maybe not half, but some of the fun of infectious disease practice is coming up with the diagnosis based upon some bizarro exposure history. And if you don't know the bizarro history, you may not know the potential cause of disease. Last podcast, I think I mentioned Q fever in people who were delivering pets as a living. Here was an outbreak of Q fever in the Amazon rainforest of French Guiana. It occurred in a bunch of brush cutters. And where did they get their Q fever from? They think it probably came from the capybara, which is not the same as a chupacabra. The capybara is a large rodent, and they found Q fever in the poop of said animals. So they think they were out chopping the brush down and got exposed to capybara poop and subsequent Q fever. Now, while I am unlikely to see that here in the Great Pacific Northwest, who knows? You may see a febrile patient who just got back from French Guiana and spent their time clearing brush. You may scoff, but I once saw a patient who had disseminated histoplasmosis who picked it up in Central America when he was clearing brush and then came across a cave that he crawled into. So people do the damnedest things to pick up infectious diseases. So I wouldn't entirely discount the exposure to the capybara, and people also have the damnedest things for their pets. My theory always has been that if you have no personality or you are fundamentally uninteresting, you make up for it by having a bizarro pet. Rickettsia are a growing problem, and they keep coming up with new ones, again out of China. This one is Rickettsia xinjiangensis, which causes a spotted fever in Xinjiang, China, Xinyang. So they named the virus after themselves. How Mayo Clinic of them. But there have been a bunch of different Rickettsia described out of China of late. And then we still have Rickettsia felis, which I suspect is underdiagnosed. It comes from cat fleas, and it causes a variety of illnesses. This was a report of 2 cases of acute meningoencephalitis that was due to Rickettsia felis. Not only is it found in cats, it's also found in possums, which are fairly ubiquitous here in the Great Pacific Northwest. Last time I looked, there was no readily accessible serology to find diagnoses with Rickettsia felis. At least ARUP doesn't offer it, and I suppose I could get a positive with the Carius test, but whenever I have someone with a doxycycline deficiency state, low white count, transaminitis, fevers, no good reason, and I'm worried about Rickettsia, I've often wondered about Rickettsia felis as the cause, but to date I've yet to make a diagnosis. And of course there's also Rickettsia typhi, the cause of murine typhus. And if you're planning on going to a trip to Galveston in the near future, just to let you know, they're seeing an increase in cases of murine typhus in Galveston. Texas seems to be a particular hotspot for the emergence of all sorts of awful infectious diseases. It may be a state best avoided, especially as I mentioned before, the Houston area. By the way, if you hear a bunch of snorting in the background, that's not me. It's my son's bulldog, who is quite the troublemaker, and he's up here exploring around while I'm doing the podcast. He's an adorable little mutant, but man, is he loud. There is a vaccine that they give cattle to prevent brucella. It's Brucella abortus RB51, a live attenuated vaccine, and cows who get it, of course, don't go on to get brucellosis. There have been cases of that organism causing brucellosis in people who were inadvertently exposed to the vaccine. Now there is a case report or 2 in the MMWR of people who got brucella from the vaccine strain from drinking raw milk. I like to point out that gravity is an important feature, and if you look at the position of the cow's butt and the cow's udder, you'll see that that might not be the best source from which to drink raw milk. And there was also a report on brucella in lab techs in New York City. What I did not know was the most common infection for a lab tech to pick up is brucella when they're not warned. I always warn the lab if I'm worried about potentially infectious diseases, i.e. those they could pick up off the culture media while trying to identify the organism. And one of their recommendations is to not use automated systems such as the MALDI-TOF for identifying the organism until you know it's not an infectious organism like brucella or tularemia. I see a Legionella a year, tops, here in the Great Pacific Northwest, despite how wet it is. Although I suspect things are getting muggier. It sure seems that way. And we're having more thunder showers, so perhaps more Legionella is in our future. This study looks at patients who either respond slowly or not at all to their Legionella therapy. And in this series, all the patients had susceptible organisms, but interestingly, they went on to develop either a lung abscess or, in 2 cases, empyema. And these patients got prolonged courses of antibiotics with a median of 46.5 days, one as many as 92.5 days of therapy for their legionellosis. These were all, by the way, immunocompetent patients as well. I will admit I can't remember if I've ever seen a case of slowly resolving Legionella, nor have I ever seen a case that's gone on to develop a lung abscess or an empyema. That is likely due to the rarity of legionellosis here in the Great Pacific Northwest. And in the world of spirochetes, there is, or was, a rodent-borne outbreak of leptospirosis in a prison. This was in a South African prison, but I would not be surprised if rats are present in all prisons. So keep that in the back of your mind should you see a patient coming with an unusual fever out of prison. You can also get leptospirosis from dogs, and this study looked at leptospiral shedding in shelter dogs in southeastern Appalachia, and they found 13 to 18% of dogs had leptospirosis, depending on the methodology used to diagnose the organism. That 13% was in the urine, so you don't want no shelter dogs pissing on your front yard or being brought home for training until you know they don't have leptospirosis. And there is a unique form of relapsing fever in Spain. Well, it's a unique Borrelia hispanica. Again, how Mayo Clinic of them. It's not like the old days of syphilis when the French called it the English disease and the English called it the German disease and the Germans called it the Spanish disease, etc., etc. In modernity, when you identify an organism, you name it after yourself or your locale and not implicate your neighbors by naming it after them. Long-term use of antibiotics as a prophylaxis is always problematic, although it's standard with patients with chronic ascites to prevent SBP. But the problem is resistance develops. And if you have a patient who develops quinolone-resistant or MDR-resistant flora in their colon, they break through their prophylaxis. This study demonstrated that fact and suggested that in patients who are on chronic suppressive antibiotics, it may behoove you to do screening for MDROs and alter their prophylaxis accordingly. And that way, by constantly changing antibiotics to match the flora in the gastrointestinal tract, you'll soon have patients in ascites with completely resistant infections. Use it and lose it. You could say that there are 2 kinds of Klebsiella, the hypermucoviscous strains, which tend to cause abscesses, and the non-hypermucoviscous strains, which tend not to cause abscesses. However, what are the other risks for developing an abscess if you should happen to have a patient with Klebsiella bacteremia? Besides the hypermucoviscous strains, the risks out of this study were male gender, diabetes, neurologic disorders, recent chemotherapy, and something I'll never discover, high C-reactive protein levels, because I virtually never order C-reactive proteins. So a diabetic male just finishing up their chemo with Klebsiella in their blood, worry about an abscess. As long as we're on the topic of gram-negative rods, there's an article about Shigella that suggests that resistance to oral third generation is a problem. They had several cases where patients were treated with an oral third generation for the Shigella sonnei infection and failed. So in treating Shigella, beware the oral third generation cephalosporin. Most of the time, repeating blood cultures to document clearing of the bacteremia is a waste of time. It is virtually always a waste of time for streptococci, which are nuked by a single dose of antibiotic. And with gram-negative rods, it's problematic. Most of the time for the Enterobacteriaceae, it's a waste of time to repeat blood cultures to document clearing of the blood. As a rule, the only time the bloodstream isn't cleared is when you have the patient on inappropriate antibiotics. This study looked at follow-up positive blood cultures and found, although repeat cultures being positive were rare, who's at risk for having repeat positive blood cultures with gram-negative bacteremia. And those at risk would be end-stage renal disease on dialysis, having an intravascular device, and resistant organisms, i.e. extended spectrum beta-lactamase or carbipinamase producing organisms. And I can't tell that it made any great difference in outcomes, however, if they had positive blood cultures. Those who had follow-up blood cultures that were positive had the same in-house mortality, but they did have a slightly longer 2.5 days length of stay in the hospital. Interestingly, those who did have follow-up blood cultures that were positive were more likely to have eclampsia, which is probably a good reason to have a recurrent bacteremia, a reason to repeat the blood cultures, because you're looking for an endovascular infection and subsequent removal of the line. But I think the reason to repeat blood cultures in patients is twofold. One is if you're worried about an endovascular infection, and two is the patient not responding clinically, so you're worried about some undrained abscess, etc. But I think the bulk of the literature suggests that for most gram-negatives and all gram-positives, with the exception of Staph aureus, it's almost always a waste of time and money to repeat blood cultures. Then they also have the coag-negative staph contamination, which leads to more blood cultures and unneeded vancomycin. And as I had mentioned before, I think starting antibiotics from the first negative culture is silly and has no supporting literature for that practice. I tend to only order cedrates when I'm worried about polymyalgia rheumatica temporal arteritis as a cause of my FUO. I virtually never order C-reactive proteins, which, when you think about it, really should have the acronym CRAP. And I never order procalcitonins. This study looked at the procalcitonin as a marker for bacteremia and found that it stunk on ice. Its sensitivity was 62% if your threshold was 0.5, 76% if your threshold was 0.25, and 92% if your threshold was 0.1. But they pointed out that patients with a quote negative procalcitonin were admitted to the ICU and not given antibiotics, and subsequently were found to have infections and bacteremia, and that you cannot use a procalcitonin for withholding antibiotics in someone in whom you suspect bacteremia. Of course, I've trained in the pre-procalcitonin era, and I never bothered to order them, and they're not available in my hospital. And like cedrates and CRP, I have yet to figure out their utility in the management of patients. And a report on the causes and outcomes of spontaneous meningitis in diabetics, Not unsurprisingly, they had poor outcomes, but the top 2 organisms to cause meningitis in diabetics were Strep pneumoniae and Listeria. I have to admit, the Listeria kind of surprised me, but this was out of Spain. And European dietary habits, especially with cheeses, etc., are definitely different than U.S. dietary habits. But 18% of their meningitis were due to Listeria. And another study on the relevance of a persistently negative 1,3-beta-D-glucan in patients with candidemia. So they had a bunch of patients who had Candida in their bloodstream, and they had negative beta-D-glucans repeatedly, and they had very good outcomes with their candidemia. And it's a curious study. If I have a patient with candidemia, I almost never bother checking a 1,3-beta-D-glucan unless I'm worried about endocarditis as a complication of the fungemia. And if it's negative and I have checked it, I don't check it again. Why would you check an average of 4 beta-D-glucans in someone whose first or even second was negative? That makes no sense to me. And I know it's not a perfect test, but why bother? I get a beta-D-glucan if I'm worried about candidemia and my cultures are negative, and I know there's a lot of problematic issues there, or if I have a patient with fungemia and I'm worried about an endocarditis as a complication. But generally speaking, if I have candidemia and they respond to the antibiotics, that's where I stop. At $200 a pop, why would you get 4 beta-D-glucans in someone when they're all negative? I mean, why not just hold up $100 in front of the patient and burn it once a day? CID calls this a major article, but I sometimes think they have a very low standard for what they consider to be major, because this was goofy. Or maybe I'm just missing something. Probably. A nice article in Emerging Infectious Diseases of blastomycosis as a problem in Minnesota, predominantly northern Minnesota. The article did have a line that made me giggle, having done my residency in Minnesota and having met my wife there. It says, quote, "The typical blastomycosis patient in Minnesota is a 45-year-old white male who spends time outdoors." In other words, every Minnesotan, or at least 50% of them, just walked the Minnesota State Fair, middle-aged white men being outside. Although in the Minnesota State Fair, in one hand they have a bucket of chocolate chip cookies, and in the other hand they have a deep-fried turkey leg. Oh yeah, sure, don't you know, I know my Minnesotans, and am not hesitant to resort to stereotypes. If you've ever treated coccidioidomycosis, you know it's a tricky disease. Even uncomplicated pneumonia has all these rheumatologic manifestations. They get arthralgias, they get enodosum, they don't feel well, their serologies are variable. You check it and it's 1 to 16, and when you recheck it, it's going up instead of down, and you're worried about do they have meningeal findings. And cocci is a tricky disease. There is a wonderful discussion of this by Dr. Galgiani et al. In CID called Treatment of Early Uncomplicated Coccidioidomycoses. What is success? ? And they address those issues that make treating cocci such a conundrum, such as the ongoing joint pains, or what to do about the serology, or what to do when patients get better clinically in some respects but continue to feel poorly, or what do you do about their headache that waxes and wanes when they don't have meningitis. And for all those issues, there is no data, but Dr. Galgiani et al. Go through their clinical experience with this interesting and complicated fungus, and it's well worth your time if you ever get a case, or if you just like an interesting article on a complicated, curious disease. I am always leery of the phrase, "in my experience," when it comes to treatment of any disease. However, sometimes all you have is a vast clinical experience by an excellent clinician, and it's always worth the time to read those articles. And that's it. That brings us to the end of a Puscast covering the last 2 weeks of April in the year 2020. Winston, my son's dog, and I wish you health and happiness. The references are available online at edgydoc.com. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, and take it away, Jeff.
China, 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 China. I've been saying China, 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 China.
Let me ask you about China.
China. I go to China. China, 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 China. People from China, they love me. China, 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 China. In China, they say I don't like China. I love China. People think I don't like China. I love China. China. China is the new China, by the way. China, China, China. I deal with China. China, China, big league, China. So don't tell me about China. I know China. China, 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 China. Whether it's China, China. So if you went to China and you wanted to get a job in China, I don't knock China. How could I dislike China? A man from China. China. You have China, Carl. Take China. China, China, China. China. China, 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 China. China's over here. Look at what China's doing. They're learning from China. China, China. Okay? Look at that. Isn't that nice? China, 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 China. China, 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 China. And by the way, I love China. I mean, I love China. How can you not love China? I love China. China, China. China, 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 China. China, 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 China. And you know China, 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 South China, China, China. People say, oh, you don't like China. I like China. China. I love China. China. China all the time. China. When was the last time you heard China?
Sorry, I couldn't resist.